Hello everyone, my name is Max Rusek. I'm one of the PGY2s here at OHSU, and I'm here virtually to discuss my case titled Azotemia due to a urinoma, a not-so-bland case. As an introduction, urinomas, also called pararenal pseudocysts, occur when urine collects in the retroperitoneal space when it becomes extravasated from the collecting system. Their formation and subsequent reabsorption can cause azotemia out of proportion to renal function and should be a diagnostic consideration when evaluating azotemia. To discuss this case more specifically, a 69-year-old male presented to the ED with a 2-day history of anuria preceded by 3 weeks of hematuria and malaise. Past medical history is notable for coronary artery disease and BPH, and the medications are listed below. On presentation, vital signs were within normal limits. An exam was notable for diffuse left-sided tenderness on deep palpation and prostate tenderness on digital rectal exam. Labs were notable for creatinine of 15.5 from a recent value of 1 3 months prior, with an associated BUN of 147 on presentation. Potassium was 3.9, bicarb was 14, and there was an anion gap of 19. Urinalysis showed white blood cell count of 19 with 3 RBCs and no CAS. FeNA, or fractional excretion of sodium urine, was calculated to be 1.7%. In the emergency department, a bedside bladder scan showed a distended bladder, prompting placement of a Foley catheter, which drained 1.5 liters of clear yellow urine. An ultrasound was initially obtained that showed right hydroureter and no other abnormalities. A CT abdomen pelvis was subsequently obtained, which showed a complex retroperitoneal fluid collection measuring 16 by 11 centimeters, seen here in the middle of this poster in the coronal and sagittal views. Interventional radiology was subsequently consulted and placed a retroperitoneal drain, which drained clear, dark fluid with a subsequent analysis that showed a creatinine concentration of 71, consistent with a urinoma. The patient was eventually discharged with a Foley catheter and retroperitoneal drain in place. At 2 weeks post-discharge, a CT scan was obtained showing resolution of the urinoma, seen in the bottom picture in the middle column, prompting drain removal 1 week thereafter. In regards to an etiology, during the patient's admission, a prostate-specific antigen, or PSA, was checked and was elevated at 108. At outpatient follow-up, this continued to be elevated at 117, prompting prostate biopsy 2 months after discharge. Eventually, the patient was diagnosed with stage 3 prostate cancer with a Gleason score of 5+4, and the patient is currently undergoing androgen deprivation therapy. For some case reflections and teaching points, urinomas occur most commonly due to trauma, instrumentation, or due to obstruction. Complications include electrolyte abnormalities, abscesses, and urosepsis. Treatment includes drainage of the collection and possibly percutaneous nephrostomy tube or ureteral stenting to promote urinary flow and thus healing. It is hypothesized in this patient's case that the patient's prostate cancer caused repeated episodes of urinary obstruction, thereby increasing the pressure of the collecting system, eventually causing the creation of the urinoma, which has been described in previous case reports. I want to thank you for listening to this presentation, to Dr. Akram Khan of OHSU for being the attending of this case. I want to acknowledge the patient for letting us be a part of their care. Thank you for your time.